Hey, good day and good evening, everyone. Welcome back. It's Tuesday, it's IVF webinars again, and good to see you all here back. And before we start, I would like to ask you to give me a sign that everything is working, that you can hear me loud and clear, hopefully, and it will be a huge help. Yes, and thank you for the feedback already. And yes, thank you again. Good evening, ladies and gentlemen. I am Sophie and I'm your host today. Welcome to IVF webinars by Egg Donation Friends. Every week, we are here to share IVF knowledge with you and to link you with best fertility experts and also answer lots of your questions. All IVF webinars are recorded and all our IVF webinars are available for you 24/7 at our website, eggdonationfriends.com/IVF-webinars. IVF webinars are brought to you with help of our partners, and our partners are National Fertility Society, fertility clinics abroad, and Donor Conception Network. And tonight, we are here together with Dr. Elena Santiago, gynecologist and fertility specialist at Clinica Tambre. So we say good evening to Madrid. Hola, Madrid. Hola, Dr. Elena. How are you?
Hola, good evening to everyone. Thank you very much for the introduction.
Yes, and Dr. Elena will be doing the presentation tonight about IVF and women over 38, treatment options, prospects, and limitations. And Dr. Elena aims to personalize each patient's case and adjust treatment accordingly to the needs. So she will be also the great person to answer all your questions. And if you have any, we will have the Q&A session after the presentation. So you can prepare your questions or type your questions, even starting from now, if you have any questions already. The presentation will take around 25 minutes, and next we will follow with Q&A. So not wasting any more time, we can start the presentation if only Dr. Elena is ready to start.
Yes, I'm ready. Thank you.
Yes, thank you.
Okay, so first of all, thank you to everyone for being there this evening to listen to us. And well, I hope you take profit of everything. So, well, let's talk about, as we said, IVF and women over 38 years old. What will we cover in this topic? Well, first of all, I would like to explain a little bit more about ovarian reserve. We will see as well age and reproduction. What does it mean? Why is it different when women are older? What will this also do in prospects and also limitations that we could have in reproductive outcomes? And finally, we will talk about the treatment options that we can have for 38 years old onwards. So first of all, what is the ovarian reserve and how can we calculate it? So this is something that maybe we hear quite a lot, but not always we know exactly what it is, or how can we know what is our ovarian reserve. So it's very important that you understand the concept that women are born with all of their eggs in their ovaries, and this will be reduced with time. So it also means that we are not able to produce new eggs within time. This is completely different to men, as they each 3 months are going to produce new sperm. But here it's completely different. So what factors are going to influence in that ovarian reserve, as this is not always exactly the same in each woman? No? So first of all, age. As you can see at the graph, the ovarian reserve lowers most of it normally from 35, 40 years old onwards. But there are other factors that could influence, such as, for example, toxics, way of life, the environment, gynecological pathologies, such as, for example, endometriosis, or if we had any other pathology that needed ovarian surgery, could affect this ovarian reserve. And also, sometimes we have to also take into account the family background, because there is like a genetic situation where we can have premature menopause in the family, and sometimes this could deliver in an ovarian failure when women are very young. And last of all, when there are pathologies such as oncologic, and we need a therapy such as chemotherapy or radiotherapy, we know that these types of treatments can or will affect the ovarian reserve. How can we calculate what is our ovarian reserve? So there are nowadays two basic tests that we should do in absolutely every woman that is going to do a fertility treatment or that is having problems to get pregnant. First of all, we can do an ultrasound or a scan at the consultation. It's very, very easy, normally vaginally, so that we can see better the ovaries, but it's so easy to see the ovaries. And there in the image, what you can see is an ovary, and the black images inside are called follicles. So these are small liquid sacs that should contain, each of them, one egg inside. And we are going to count how many follicles we can see at each ovary so that we know how is the ovarian reserve. Meaning that when we have between 10 to 20 follicles between the two ovaries, that's going to be our normal ovarian reserve. If we have less than 10 follicles, that will be a low ovarian reserve. And if we have more than 20, which can happen as well, we will have a very high ovarian reserve. So that you understand what the follicles are, in each cycle, women are going to have new follicles that appear in their ovaries. So one of those follicles naturally is going to grow during the cycle to produce the ovulation. So we only ovulate one egg, but the rest of the follicles will disappear. So that you understand this, we are losing many eggs in each cycle. And the idea of the antral follicle count help us to know how is the situation, because the proper egg is microscopic. So as we can't see that, then we don't know how many eggs are left over. But if the woman is having each cycle more or less like 10 follicles, 15 follicles, then that's a normal ovarian reserve. And second of all, what is the other test? It's very important. It's very, very specific. It's called the anti-Mullerian hormone. This hormone is produced over there at the follicles. So we can do a blood test. It's very easy. We don't need to be fasting. You can do it at any time in the cycle. And depending on the result, we will compare it as well to the scan to see whether we have normal, high, or low ovarian reserve. So over there, you have more or less the numbers that we use. Sometimes it's measured in nanograms, sometimes in picograms, but well, that's the idea of how the ovarian reserve works. So this was an important part, but we should get through another very important part for fertility treatments, that it's the age, no? Age, as we said, is always related to ovarian reserve. And very important too, it's going to be related to ovarian quality. The problem here is that we can't test the ovarian quality, because nowadays there are no tests that exist for this. So we have to take into account always the age of the woman to more or less know how is going to be the ovarian quality, because it's not the same, or ovarian reserve is not dependent in quality. It's true that women having low ovarian reserves can have worse quality than a woman having a normal ovarian reserve. But if, for example, I have a patient that is 42 years old and has a very, very good ovarian reserve, I have to know that her quality is not going to be so good. Okay, so that's what we are going to understand now with these graphs. So, for example, in this one, in this image, what you can see is how proportional is the decrease in the ovarian reserve within age, as well as the antral follicle count that we saw with a scan image, and in the same way the anti-Mullerian hormone. The three altogether will decrease absolutely in the same way, but not always in the same way for every woman. Okay, this could be different. And well, in this graph, we can see also the FSH, which is another hormone that sometimes we measure as well for ovarian reserve, but it's less specific than the other one I told you, the anti-Mullerian hormone. But FSH, well, will increase. It's completely the other way around within age. For example, when a woman has menopause, FSH is going to be very, very high. Just so that you have a little bit about this concept. So, following all these explanations that we gave, the percentage of the rates of fertility depend on basically age and ovarian reserve, both of them. So here at this graph, you can see that the maximum percentage of fertility is around 20 to 24 years old. Maybe it's quite good too until 30 years old, but from there on, it decreases completely, achieving a very low a very low fertility rate from 40 years old onwards. Nearly, it can become zero. Okay, so either ovarian reserve quality, as we said, will decrease with age, and therefore fertility rates will proportionally decrease. Here is another graph where I wanted to explain to you, as well as time passes, well, live birth rate will be lower, as we saw, no? Fertility rates are lower, but also due to, as we said, quality. What does a bad egg quality mean? Well, basically what it means, as we are going to see now, and I'll explain you, but basically, this means that if we achieve, when doing a treatment or in a natural way, if we achieve an embryo, this is egg and sperm when fertilized, if we achieve an embryo, within age, the probability of having an abnormal chromosomically embryo is going to increase quite a lot. So there is where you can see the blue bar going up, that it's called aneuploidy. So more or less from 35 years old onwards, aneuploidy is going to increase a lot, changing the percentages. We'll see that now after you're going to understand why and the meaning of this. But as you can see, we have another line which is green, which is the miscarriage rate. So both of them are parallel, increase more or less in the same way. This is because when embryos are not normal chromosomically, they normally don't produce a pregnancy or when they do produce pregnancy, they normally will provoke a miscarriage during the first weeks of pregnancy. And this increases with age. So that's the important thing. So having all this information we talked about right now, what are the prospects and limitations when doing assisted reproduction techniques or treatments? Well, I wanted to mention a little bit about an IVF. Maybe some of you already know, but there are different types, as we can use our own eggs and our partner's sperm, or own eggs with donor sperm. When we are not able maybe to use our eggs, we can go for an egg donation with either partner or donor sperm. And finally, there is another treatment that we call ROPA, which we use in lesbian couples. That means that both women are going to participate in, let's say, the technique. One will be the donor of the eggs, and the other one will be the recipient of those eggs, carry on the pregnancy. I wanted to mention that all our treatments will include ICSI. This is a very important concept too in the fertility world. It means that when doing the fertilization, we will use spermatozoa previously selected by the biologist, which moves, has a good morphology, and we will inject it directly in the egg. So that's what ICSI or spermatozoa microinjection means. This is to go a little bit, to review a little bit more what the IVF is. It's a treatment where we have several stages, as you can see. And normally, let's say that basic IVF is recommended in women that are aged less than 38 years old. You'll see now why. Maybe that they have a low ovarian reserve already, or they have problems such as endometriosis or polycystic ovaries, or maybe they've done previous treatments such as insemination and it didn't work. So as you see the stages, first of all, we do an ovarian stimulation, afterwards an egg retrieval to achieve the eggs at the lab. We have a sperm sample from the donor or the partner, and with those we will do the fertilization in the lab to achieve the embryos, see their quality, choose the best one for the transfer. This means putting the embryo inside the uterus, and about 11 days after we will do a pregnancy test to see if it worked. I just wanted to give like the idea of the, let's say, simple or basic IVF treatment. Here I wanted to show you the success rates in IVF depending on age. These are our results. So it's quite general, but as you can see, it changes quite a lot, even with a treatment. So when we are less than 35 years old, we can achieve nearly a 60% chance of getting pregnant. Between 35 and 40 years old, it will lower a little bit until 56%. But you see that here we have 5 years of different. It's very different. Women of 35 years than 40. And here you are above 40 years old. Normally, we won't achieve more than 34%. But we have to personalize, individualize each case, and depending on the age of each woman. Here, I wanted to show the success rates in IVF compared to egg donation, depending on the age too. So as you can see, the pink bars represent IVF success rates at our clinic. So in the same way, we will be lowering those rates depending on the age. But as you can see, the other type of treatment, which is egg donation, doesn't change at all with the age of the women or the person who is doing the treatment, the recipient, we call. So this is so that you can have an idea how age will always be so important in success rates. So talking about women aged more than 35 years old, what are our treatment options? So here comes the important part. What can we do to achieve the best success rates? Because normally we have to do something else apart from only insemination or IVF. So for example, in IVF treatments, we will always recommend to do something else, which is called the PGS, or preimplantational genetic screening. And sometimes, if we are not able to do this treatment or it doesn't work, then we will go for an egg donation. That, as you can see, will give us very, very good results, even if we are older than 45 years old. So what's the PGS? It's an, let's say, extra procedure in IVF, where what we do is that once we have embryos in the lab, nowadays we're talking about embryos in day 5 or day 6, which are called blastocysts. And what we are going to do is, before the transfer, before putting the embryo in the uterus cavity, we're going to biopsy it. We're going to take about 10 cells. Here, the embryo is called blastocyst and has many, many, many cells already. So we are going to take about 10 and we are going to test them for the chromosomes. As I said before, one of the problems with age is that the embryos will be normally abnormal chromosomically. So we need to see this to have a better selection of the embryo that we are going to put inside the uterus. And this will increase quite a lot the chances of success rates, as well as having a healthy baby. And it will reduce quite a lot, not 100%, but quite a lot, the risk of miscarriage. And also, it will reduce the duration, let's say, of treatments, because if we can achieve several embryos, which will be the best, then if we are doing another selection and maybe we biopsy about, 3, 4, 5 embryos, and within those we only have 1 or 2 healthy ones, then we are not going to do so many transfers trying for pregnancy. We're going to use only the ones that we know that can achieve a normal and healthy pregnancy. So here you have percentages and data that could help you to understand better the aneuploidy thing or chromosomically normal embryo thing or statistics. In the left table, we can see that when women are aged less than 35 years old, we can have about 50% of normal embryos when doing an IVF. So half of them will be normal and the other half won't. But you can see that when we are older, when we are more than 40, 42 years old, this percentage lowers a lot. So this is very, very important. For example, women above 42 years old, only 10%, about 10% of the embryos is going to be healthy. So meaning that maybe if I achieve 10, which is a lot, only 1 is going to be healthy. At the right-hand side is another way of explaining this in terms of chances of having a normal embryo per number of embryos biopsied per age. So you can see the green part reduces within age, and there is where we can see that maybe when we are younger, we only need 1 or 2 embryos to achieve one that's normal. But when we are older, more than 40 or 42 years old, maybe we need to achieve more than 5, 6, 7, 8 even embryos to try and achieve at least one normal. So here, the concept of ovarian reserve is very important, because if I have an old woman that has a very, very low ovarian reserve, then maybe I'm only going to achieve one embryo. And therefore, the probability of achieving a healthy embryo within that embryo is going to be very low, maybe less than 10%. Okay? Here there are other graphs to show you a little bit more, to learn a little bit more about all this we've talked. So the PGS minimizes the negative effect of maternal age in the implantation rates, because as you can see, when we're doing the transfer of only healthy embryos, there is no difference within maternal age. We have the same results. Between 50, I would say, even until 70% chances of getting pregnant, even if I'm older. So if I finally can achieve with 40 years old or 42, if I'm lucky and I achieve a healthy embryo, the probability of that embryo implantating or producing a pregnancy is very high, 70%. But if we do only an IVF without PGS, you can see how the success rates lower within time. The last graph here underneath it shows that when older, the number of cycles without transfer increases. This is because with low ovarian reserve within age, we will sometimes not achieve even a good morphologically embryo to transfer. But when we achieve in the same way normal chromosomically embryos and we transfer them, there are no differences within age. And finally, let's talk about egg donation, because obviously, depending on the situation, we don't always have the option to go for an IVF with a PGS. So we have to go directly for an egg donation, or maybe after trying other treatments that didn't work. I wanted you to know that here in Spain, egg donation is anonymous. We do loads and loads psychological, medical, genetics tests. We select them with these tests as well as with age. They are normally aged less than 30 years old with obviously no reproductive problems. And we will choose the donor depending on physical characteristics of the recipient, of the woman doing the treatment. And they will follow, the donor is the one that will follow up an ovarian stimulation and an egg retrieval at our clinic to achieve her eggs. The recipient will do here a completely different treatment, which is maybe easier, so there are advantages too. She will need normally to do a synchronization with the donor so that her uterus is prepared at the time we achieve the embryo from the egg donation. This endometrial preparation is normally done with pills or patches. And the embryo transfer is completely the same. We can also do PGS if we need to or if we want to. And after all the treatment, once the woman is pregnant, we'll say that pregnancy is exactly the same as if we achieved it with her own eggs. She will be a real mother. I would like to talk a little bit more about the selection of the donor, not only physical characteristics, as we said, but also we're going to see the blood type of the partner, of the woman doing the treatment. We can also use an IT program at our center that is called PhenoMatch. This means that with a photograph of the recipient, we are going to compare her face with several donors to see the one or select the one that matches better. There always will be doctor and patient communication during the procedure, and if needed, we can do even immunological matching with the donor. And as well, one of the options in the treatment is if you want to do a genetic matching with a donor. This means that we are going to search for several mutations in the partner to match with the donor and avoid diseases. This type of genetic matching can also be done when using egg and sperm donation, so that there are no genetical, let's say, diseases within the donors. So how do we do the selection of the donor? Well, first of all, they come to the clinic. This is completely free for them. I mean, they come by themselves. They will have a first visit with the nurse team so that we can see if they have any healthy problems or medical conditions in their families. If everything is all right, then second of all, they will do a psychological interview with our psychologist, several tests too, and if everything is correct, then finally we will do all the health tests or research. So here you can see all the tests that we always do to all donors. General blood test, gynecological tests, and genetic, meaning that we do always karyotype. We do the basic, let's say, recessive mutations, the most important in our population, so that the donors never are carriers of these recessive mutations. And the matching means that within those recessive mutations, we will study more mutations until 300 diseases, just to see or to avoid any problems in the baby. Okay. Here we are going to compare the egg donation success rates, pregnancy rates at our clinic when using partner sperm and donor sperm. With donor sperm, it's a little bit higher, the percentage. That's the difference. And what does cumulative pregnancy rate mean? Well, when we do the first transfer of one embryo, we can achieve until 77% chances of getting pregnant, with donor sperm even 70%. But obviously, if it didn't work in the same place or in the first attempt, we could try again with other embryos if we have leftover, that normally we do. And obviously, the cumulative pregnancy rate will increase with transfers. So a second attempt, we can achieve more than 85% in both treatments. And when doing 3 transfers, we can achieve 98 to 99% of pregnancy rate. And well, finally, I wanted you to take some messages home. So what are these ideas? First of all, the ovaries, we know that they have their optimum time to operate. So the sooner we do something, the better, because always quality and ovarian reserve is going to decrease within time. Women have to be very aware of this, okay? Well, talking about fertility and outcomes, as we saw. Over 38 years old, we should add always, very, very recommended, a PGS to the IVF treatment to increase pregnancy rates. And finally, when ovarian reserve is very low, we should think about egg donation as the solution directly. So thank you very much for listening to me this evening. And well, I hope it helped you.
Yes, thank you, Elena, for the presentation. Very informative one.
Thank you.
Yes, indeed, we have some questions already waiting for you. So we will go straight to the first one. And here it is. How long would I need to wait for a blonde, blue-eyed donor if I come for donor egg treatment at Tambre?
Okay, it's true that normally we don't have a waiting list, but when physical characteristics are a little bit more difficult, let's say, within our donors, we have them, but well, maybe it's a little bit more time. So we are talking about 2 to 3 months until the transfer for this type of physical characteristics.
Yes, and thank you very much for the answer to this question.
You're welcome.
We have the next one ready for you. I am going to 50 considering donor conception, never been pregnant. What are the chances of success?
Okay, so success rates won't change even if you are older than 45 years old with an egg donation treatment. But here we have to maybe take into account other things, other risks that could occur not during pregnancy because of the age. So we have to consider very, very, very carefully those risks as, for example, hypertension, preeclampsia during pregnancy, diabetes. So normally we'll have to do quite a lot of studies to see that there are no further risks for that person in particular.
Perfect, and thank you for the answer and for the question as well. And of course, we have more to answer, so let's take a look on the next one. I'm 40 years old. My AFC was 7. Then a year after, the doctor couldn't see any follicle. That doesn't mean I don't have eggs or follicles, right?
Right, that's it. Obviously, if you don't have menopause and you still have periods, we have to have eggs left over and obviously follicles. But we have to see maybe in one cycle you can't see any antral follicle, but maybe if you do the scan the next cycle, you can see maybe one or two. The idea with this is always to compare with the anti-Mullerian hormone to have more information.
Yes, great. And thank you for your explanation and, of course, for the question as well. And we will now jump straight to the next one. Yes, and this will be the next. I am looking to do IVF. What are the tests to do on the embryo?
Okay, so as we talked, well, first of all, always we are going to see the morphology of the embryos to see the chances of pregnancy, meaning that when the quality is not good, those embryos won't be used for a transfer because we don't think that they can achieve a pregnancy. And other tests that we can do, well, the PGS is the one that we've talked about. Well, doing a biopsy to see the chromosomes, and from there on, nowadays there are no more tests that we can do. I think that with embryo quality in blastocyst stage and PGS, we can have the maximum information right now.
Yes, and thank you again for your explanation and again for your questions. Yes, the next one on the list is this one. What kind of medication would you suggest to go for if every stimulation just 2 usable eggs are produced?
Okay, so here it's controversial, let's say. It depends on the patient, obviously. Normally, when we try a first or second cycle, even a third, it depends. The idea nowadays is to achieve as much eggs as we can. So normally we put maximum dose of gonadotropins. But it's true that if we've done several treatments and the response is always the same, meaning 2x each time, maybe we could reduce a little bit the dose so that it's like more comfortable for the patient and even cheaper. Uh, so it depends. Obviously, I prefer to do mild stimulation to achieve two than doing, for example, a natural cycle where we could nearly always achieve only one egg.
Perfect. Thank you again for your answer to this question. And no surprise, we have next one. So I will publish this. And the question is, do any of your donors state that they would be willing to have contact with any offspring once they turn 18? And as a clinic, would help make this connection?
Okay, so this is a very, very interesting question because, well, in each country the law is quite different. At our country in Spain, the law says for the moment that donations should be always anonymous. So there is no option at all to have contact with their offspring or the offspring to have contact with the donor. This is something that, well, there are different opinions, but we think that donation works quite good at our country because of this. Because normally, donors don't have any interest in getting in touch with the offspring after their donation. They even normally don't ask about pregnancies achieved, anything. This is information that we don't give them, but they even don't ask for it. So we could, for the moment, never help for this connection. I don't know if law could change within time. This we never know. But obviously, professionals that work with egg and sperm donation and have experience, I think that most of them, at least at our country, think that the procedure being anonymous helps us to have more donors and also patients, because I think that the recipients also prefer, the majority, not all, but also will prefer not to have a contact in the future.
Yes, thank you. And actually, we have also a follow-up comment, which is also a question. So we will take this one now, okay?
Yep.
But what about the needs of the offspring? Seems very unfair. Of course, this is like, we
Yep.
can only, yeah. For
Yeah,
now,
sure.
for now, the law is clear about that. And thank you
That's
for the explanation. Yeah.
Yeah, sure. Obviously, it all the opinions. It's controversial. No, we could talk all night about this topic, but well, some people think it's unfair, some not. I mean, is it a right that recipients, well, the offspring, know their where they come from? But also, not always people, when doing this type of treatments, will tell their offspring that they come from egg or sperm donation. So, well, it's very, very controversial. For the moment, this is the way We do it in Spain, and it has been like this since egg and sperm donation started.
Yes, thank you. Understood. And of course, as always, there are downsides and upsides. So, yeah, thank you very much. And we have the next question. So, we will take a look at this one. Can the AFC increase over time? At 36, my AFC was 9, AMH 15, and 14X, all mature, were collected in a cycle. At 38, the AFC was 11, AMH 11.6, and 18X collected, 13 mature. Also, is 11.6 PMO a good AMH at 38?
Okay, so, well, it's true that this is not mathematical, um, meaning that obviously normally it goes down with age, but it depends also in random, let's say, uh, I mean, we can't control absolutely everything. We've seen that the same patient doing two treatments from 1 month to the other with exactly the same medication could always differ. The number of mature eggs depends on the quality. We'll have to see what medication you use there. And well, picomoles, I'm not sure because I normally work with nanograms per milliliter. I will have to change that to nanograms to see if it's good. But I think it's still good if I'm because it's about 1 point something, nearly 2 nanogram per milliliter of AMH at 38, which is still good. Let's say that until 1.5 nanogram per milliliter, it's about 7 picomole per milliliter, is still good for your age.
And thank you for explaining this to us and for your question as well. Yes, and just on a fly, thanks.
Thank you to you.
Yeah. And of course, we have the next question to go. So, can you explain pregnancy rates, please? Why do they increase with the cycle?
So this is just as much times as you attempt, well, finally you will have greater chances. It doesn't mean that if I do a first transfer, I will have like 50% chances, and with the second, in total, I'll have 70%. It means that regarding all the transfers, if I did 2, finally, I can achieve a better pregnancy rate. But just because I tried 2 times to be pregnant with an IVF and an embryo transfer. So it doesn't mean that within treatments, chances are greater. Chances will be more or less the same with each transfer, but as I do more, I will have more possibilities at the end of getting pregnant.
Yeah, thank you for your explanation to this a quite complicated matter.
Yeah.
And the next question for you waiting is this one. At the age of 50, would the birth normally be cesarean?
Well, I don't think it's something mandatory, but it depends on your obstetrician, the risks and everything. I mean, if we have all factors are good, meaning that the woman has a good health situation, the baby is not very big, maybe she starts the delivery and everything goes smoothly, then why not we can have a vaginal delivery. But it's true that cesarean rates increase as well with age, because normally it's like more difficult to have a vaginal delivery and there are more risks going through every procedure or every moment of the delivery.
Thank you for detailed answer to this question. We will now jump to the next question. And the question is this one. I'd like to do PGD on all 24 chromosomes on our embryos to avoid certain genetic carrier conditions. If we get mosaic embryos, what is your opinion in transferring those, as some women transfer them, resulting in healthy babies being born?
Yeah, that's true. So normally when we do PGD, what we can get are three types of results. One is an aneuploid embryo, which normally won't be transferred because the possibility of having a healthy child is 0%. The other option is the other way around, euploid embryo. This is when the chromosomes are correct. So the embryo obviously always could be transferred. And let's say that the mosaicism, it's like the middle result, because geneticists have seen that some of the cells are normal chromosomically, but some are not. And within mosaicism, there are loads and loads of types. So here we have to see what type of mosaicism we have depending on if loads of cells are affected or not. It will be simple or like a more complicated mosaicism. And as well, what type of chromosome has the not the mutation, but let's say the problem. No, sometimes mosaicism only affects one chromosome, or sometimes it could affect even two or more. So depending on this, there is a very, let's say, complicated classification where normally gynecologists will be helped by geneticians to know a little bit more about the options of that mosaic embryo. So normally they'll give you the probability of getting pregnant, probability of having a miscarriage, and finally the probability of having a normal, healthy pregnancy and baby. So within this information, you will give it to the patient, and the patient will finally decide whether they want to transfer the embryo or not. And this is only normally an option when obviously we don't have healthy embryos or euploid embryos. If we only have mosaics, then we will have to decide together if the patient wants the transfer or not.
Great. Thank you for the answer to this question and for the question as well. We have a few questions to go, but this will be also the final call for questions. If anybody would like to ask a question, please type the questions in the chat section. And in the meantime, we will take the next one. What would be the approximately cost for egg donation?
Okay, I'm unfortunately not the person to explain about prices here. So don't worry, we will get in touch with you regarding this question, as well that you know that there are different costs depending on packages, and we can explain to you the meaning of this later. I mean, tomorrow my colleagues can contact you and give you all the information.
Yes, exactly. Just as Dr. Elena said, we will forward everything to Clinica Tambre tomorrow morning. So they will contact you and you can be all in touch. And if you need any information, feel free to do that. Okay. I will also put my email address if you would like to add anything or ask any additional question. You can always write me an email directly and I will as well forward it to Clinica Tambre. Okay, we have the next one for you, and this will be the question. Do you have black egg donors at your clinic?
Okay, yes, we have. We've done loads and loads of treatments with Black people until now. It's true that it's more difficult to sometimes not achieve donors with black skin, but we have them, and we even have a bank of eggs where if maybe during the period of time you want to do the treatment it's not possible to have a fresh donor, we can use also frozen eggs from black donors. So normally no problem with that.
Yes, and thank you. And we have the next question, which is related to the previous one, and I will publish this. And yes, maybe you can do any additional comment. Further to my question about mosaic embryos, in your experience and opinion, how many types of chromosomes and which ones are not the best ones in order to make a decision as to whether to transfer them or not?
Okay, this is quite a very, very difficult question to answer concretely, let's say. So, as I said, there are so many type of mosaic embryos. Normally, they will give you the genetic experts should give you percentages depending on the type of mosaicism, but normally the best ones to transfer will be those that only have one chromosome affected, and there are, as you say, chromosomes that could have a worse prognosis than others, such as, for example, chromosome 21, which is the one that produces the Down syndrome, is normally worst, let's say, percentage of healthy baby than others. But it's very difficult for me right now to give you exact details in each chromosome because we normally have to look at the type of mosaicism and the chromosome affected so that we can give you more information. But obviously, if you finally achieve mosaic embryos, don't worry for that. The professionals will give you the maximum information they can so that you can finally decide whether to do the transfer or not.
Yes, and thank you for handling this question as well. And we have the one more, which is taking us to the previous question about donors. The black egg donors, are they from African descent?
Yes, we have either African descent, either Caribbean. I mean, we look at that too. We look at your physical characteristics, but we ask you too where you come from. It doesn't mean that the donor has to be exactly from the same place as you, but obviously we try to match as best as we can the donor with you, taking into account also the origins. So, yes, we have African as well.
Yes, and thank you a lot for this question and for your answer. We have the next question. I have adenomyosis. Is there any treatment for this?
Okay, so right now, what we normally do is before doing an embryo transfer, we prefer to give you a treatment with, it's called analogs, during 3 months, so that we diminish the situation or try to diminish the situation of adenomyosis before doing an endometrial preparation. So it's like a, let's say, hormonal pause during 3 months with this treatment, with the analogs. And we've done it with several patients, and it worked good with them. I mean, it's not a treatment that we can say that it works 100% of the times, but it does work some of the times with patients having adenomyosis.
Yes, thank you for your explanation. Also to this question, and the next one will be about sperm. Does sperm quality age affect egg donation?
Well, sperm obviously is also important. It's true that age is not going to affect so much chances of pregnancy as women's age, but sometimes we have to take this also into account. So what can we do if, for example, the man is older than normally 45, 50 years old? We can do other tests regarding the sperm, such as, for example, DNA fragmentation, which is something that could be more affected within time, and see if we can like increase chances of pregnancy when the DNA fragmentation is not good. We can do other techniques at the lab for the sperm selection to improve our results. But in a general way, sperm quality shouldn't affect so much an egg donation treatment, even age as well. Okay.
Yes, and thank you for giving us the answer to this question. We have one more question, and this question actually came up on our Instagram, so I will put it here and display it. Maybe you can comment this. Is it possible to boost women's fertility at her 40s? Are there any medical methods able to improve it?
Okay, so this is quite a very difficult question. Obviously, I understand it completely, but it's true that nowadays we don't have yet the key to that. I mean, we are looking at different treatments to try and improve equality, to try and improve ovarian reserve, because this is the problem that we have every day with so many patients. So we are trying with that, but it's all investigation right now. I can't tell you about any treatment that's really used clinically nowadays. But I hope that in the future we will have more options for this.
Yes, great. Thank you for your opinion on this question. And in the meantime, one more question came up. So if we can take it, Dr. Elena, we will
Yes.
maybe, yeah.
Okay.
If sperm fragmentation is above 40% and morphology is poor as well as low count, can you still use it with egg donor?
Okay. At first, yes. We should see like more information about this sperm count. Sperm fragmentation, for example, is it only single-stranded DNA fragmentation, or are we talking about double-stranded fragmentation? But well, if we have enough quantity, let's say, of sperm, even if the morphology is poor, we could use techniques to improve the outcome by choosing the, let's say, less fragmented or not fragmented spermatozoa for the ICSI, for the sperm microinjection.
Yes, and thank you. And I know I told you that one question came up, but actually in the same second, the second came up.
Okay.
So yeah, and it will be the final one for today. So we will stay somewhere around this topic, but this is quite interesting question. Is it true that sperm that carry a Y swim faster and are better to result in a viable pregnancy for a boy, and that sperm that carry X results in a girl?
Well, it's true that, well, I heard about studies done with speed of sperm and, well, the outcomes, no, in the sex. But I can't say that this is true because I don't know if this is really scientifically proven. So it's something that I heard about, but I can't tell you that this is like this or in this way. What I think is that in IVF there shouldn't be differences because we are selected sperm that move. We are not looking at the speed normally and that have a good morphology. So here the results should be 50-50 when talking about sex outcomes.
Yes, great. And thank you a lot for all the questions and all the answer you gave us. And I have a lot of shout outs for you. Thank you.
Thank you.
And thank you one more time. And yes, no surprise, more thank yous. Thanks a lot, Sophie and Dr. Santiago. Thank you. Yes, I can continue with that. Great webinar. Thank you. Great presentation. Thanks. And thank you. And yes, thank you both. We can be here all night long, continuing with shout outs and thank yous. And it was huge pleasure to have you here, Dr. Elena. And thank you one more time for your time and your knowledge.
Thank
Of
you to all of you too.
Yes, of course. Thank you for everybody for being here and for your time and for your questions. Thank you, Clinica Tambre, for being here with us and for supporting IVF patients. Sharing the knowledge, IVF knowledge, and this effort and approach need to be appreciated. And I will only add that Clinica Tambre was rewarded by Egg Donation Friends as IVF patient supporter. So thank you one more time. And if you want to add anything, if you want to do any final comment, you can do that now, Dr. Elena.
Well, just to say that it was really a pleasure to have been able to do this with all of you. And well, thank you for your time.
Thank you. I will only remind you that the rewatch from today will be available on our website tomorrow. And I can only encourage you to follow us on our social media, YouTube, where we upload all the recordings from IVF webinars, Facebook and Instagram. And of course, you can follow Clinica Tambre. They have great content on their social media as well. So yeah, feel free to do that. It was great evening, good night, or good day, wherever you are, and see you soon back here again. Good night.
Good night. Thank you.